Welcome, everyone. In this presentation, we will explore how to distinguish pulse artifacts from other rhythmic artifacts seen in physiological signal recordings. Many artifacts can appear cardiac-related because they repeat with the heartbeat, but they do not all have the same mechanism. The key is to avoid judging the waveform by rhythm alone. Instead, we will use timing, waveform morphology, spatial distribution, and sensor mechanics to separate true pulse artifacts from ECG contamination, ballistocardiographic motion, respiratory modulation, muscle activity, and electrode movement. Next slide, please. A pulse artifact is best understood as a mechanical or vascular disturbance, rather than true bioelectrical activity. It usually occurs when arterial pulsation, local tissue movement, or pulse synchronous sensor motion disturbs the recording electrode or probe. In EEG, this may happen near temporal or neck vessels. In EMG, ECG, PPG, arterial pressure, and wearable recordings, it may be influenced by sensor pressure, cable tension, or body position. Although the signal may look rhythmic and biologic, its source is usually mechanical or vascular, not cerebral or muscular. Next slide, please. There are 4 hallmark features that point toward pulse artifact. First, the timing is usually linked to the cardiac cycle, but the deflection often appears slightly after the ECG R-wave because the pulse wave needs time to travel. Second, the waveform is often rounded, repetitive, and mechanically shaped, rather than sharp like an electrical cardiac complex. Third, the artifact is often strongest near a pulsating vessel or a loose sensor contact. Finally, its amplitude may change with pressure, posture, respiration, or cable movement. When these features occur together, the likelihood of pulse artifact becomes much stronger. Next slide, please. Timing is one of the most useful discriminators. Direct ECG contamination usually appears almost simultaneously with the QRS complex or other cardiac electrical components. In contrast, pulse artifact typically occurs after the R-wave because the mechanical pulse must be generated and then transmitted to the recording site. This delay is not fixed. It depends on the sensor location, vascular path, blood pressure, and individual physiology. A temporal scalp artifact, for example, may have a different delay from a finger pulse oximeter signal. The practical point is simple. Measure the delay rather than assuming that every beat-locked signal is ECG artifact. Next slide, please. When comparing pulse artifact with similar rhythmic artifacts, it is important to describe the mechanism, not only the rhythm. Pulse artifact is usually delayed after the R-wave, rounded in appearance, and localized near vessels. ECG artifact is electrical, often sharp, and nearly synchronous with the cardiac electrical event. Ballistocardiographic artifact reflects body or lead motion caused by cardiac ejection. Respiratory artifacts follow breathing rather than each heartbeat. Tremor and muscle artifacts may be rhythmic, but they are often higher frequency, irregular, and activation dependent. Motion or electrode artifacts tend to produce abrupt shifts, pops, or baseline jumps rather than a stable pulse-related pattern. Next slide, please. A practical identification approach begins by checking a reference signal. Ideally, the suspicious rhythm should be compared with ECG, PPG, arterial pressure, pulse oximetry, or an accelerometer signal. Next, measure the delay from the R-wave to the suspicious deflection across several beats. Then inspect the channel distribution. A focal artifact near a vessel suggests pulse artifact, while a widespread identical waveform may suggest ECG pickup. Morphology also matters. Rounded mechanical waves differ from sharp electrical complexes. Finally, simple mechanical tests such as securing the electrode, reducing probe pressure, repositioning the sensor, or inspecting cable movement can provide strong confirmation. Next slide, please. This workflow provides a structured way to avoid misclassification. Start with the observation of a rhythmic signal, then ask whether it is beat-locked to the ECG. If it is not beat-locked, consider respiration, tremor, muscle activity, or electrode motion. If it is beat-locked, the next question is whether there is a delay. A near-zero delay favors ECG field contamination, while a consistent delay after the R-wave supports pulse artifact. The final step is confirmation by examining localization, morphology, sensor position, and a pulse reference, such as PPG or arterial pressure. Beat locking is only the beginning of interpretation, not the final diagnosis. Next slide, please. Several pitfalls commonly lead to diagnostic errors. One is mistaking pulse artifact for clinically meaningful rhythmic activity, such as epileptiform discharges or abnormal brain rhythms. Another is assuming that every beat-locked artifact must be ECG contamination. This overlooks the importance of pulse transit delay. Mixed artifacts can also occur. For example, a recording may contain both direct ECG pickup and pulse-related mechanical motion. Overfiltering is another problem because filters may suppress the visible waveform while hiding clues about the true source. The safest approach is to identify the mechanism before correcting the signal. Next slide, please. Consider a temporal EEG channel that shows a repetitive waveform with every heartbeat. At first glance, it may appear concerning because it is rhythmic and recurrent. However, the waveform occurs about 200 milliseconds after the R-wave, is strongest in one temporal channel, and decreases when the electrode is repositioned away from the superficial temporal artery. These observations strongly support pulse artifact. This example shows why beat locking alone is not enough. The signal is cardiac-related, but it is not direct ECG contamination and not epileptiform activity. Next slide, please. The safest framework is to ask 4 questions. First, when does the waveform occur relative to the ECG? A synchronous deflection suggests ECG field artifact, while a delayed deflection suggests pulse-related mechanics. Second, what does it look like? Rounded mechanical morphology differs from sharp electrical complexes, spiky muscle activity, or abrupt electrode pops. Third, where is it strongest? Focal activity near a vessel supports local pulse artifact, while widespread identical patterns suggest field pickup. Fourth, can mechanics change it? If repositioning, securing, pressure reduction, or cable fixation alters the waveform, the source is likely mechanical. The final rule is this: beat-locked does not always mean ECG contamination. Accurate classification requires timing, waveform, spatial pattern, and mechanical context together. Next slide, please. Thank you for your attention. I hope this presentation has provided a practical and reliable way to distinguish pulse artifacts from other rhythmic artifacts in physiological recordings. By combining timing analysis, morphology, localization, and sensor testing, we can reduce misinterpretation and improve the quality of clinical and signal processing decisions.